Now we're moving to the second lecture, and it's one of my preferred really topics, which is a new fashion now for the ERAS. And we've been last week we having a very excellent also presentation from Dr. Nabil from the United States about the enhanced recovery in orthopedic anesthesia. Now we are moving into a very talented, innovative speaker is Professor Medhat Shalabi, and he's personally, I'm really honored to be presenting him tonight. He's a founder and president of the Pan Arab and Middle East Society, and he's vice president of the World Society of Intravenous Anesthesia, the SIVA, if you know about it. And he also a head of anesthesia and preoperative medicine department in Reem Hospital, Abu Dhabi, in United Arab Emirates. So we all know that it's the enhanced recovery is one of these really topics which has become established standard for our daily practice, and actually all if you all aware now, all the Western world, they are more interested in getting the patient as quick as possible out of the hospital. And the anesthetists play a unique and vital role in this success of the all ERAS programs in every specialty. And the strategies and protocol requires a dedicated and organized team for all in the hospital to get this successful patient as quick as possible ambulated and discharged from the hospital. So I'm leaving you now with an expert, with Professor Medhat Shalabi, and I'm 100% sure that you will enjoy the next lecture. So over to you, Professor Medhat. Thank you.
Thank you very much, Mohammed Mustafa. It's an honor. Thank you very much for the Dr. Saad Mahdi and to everybody. And it's my pleasure and honor to be among this elite group of anesthetists and the perioperative medicine physicians, because this is the right name for our specialty now. And that's why I insisted that my department in the new hospital will be named as Perioperative Medicine Department. And this is the first thing we have to know. Let me first introduce you, or just to give you the definition of enhanced recovery after surgery, because this is very important for all of us to understand. So ERAS, or enhanced recovery after surgery, they are protocols and they are combinations of evidence-based. So none of what I am going to tell you today, or what you are going to hear in anything about ERAS, is not a personal opinion. So none of what I'm going to tell you is my personal opinion, but it's to the best available evidence as we speak. And this is very important, because in ERAS, we fight dogmas of many people trying to say this is the way I do things, this is the other way I do things. And I'm an old man. I started anesthesia, and I started when medicine, when you can go to an exam and they tell you, if you go to Professor X or Professor Y for the same question, you will answer in two different answers, because Professor X believes in one thing and Professor Y believes in another thing. This is not right. It's now to the best evidence. And we should be prepared that in few years, if the evidence changes, we should change our practice to the best available evidence at the time of doing things. And it's perioperative. And this is very important. It's perioperative and suits very well what we say. It's the perioperative medicine, and that's why the name is perioperative medicine. So it's perioperative, preoperative, intraoperative, and postoperative. And Dr. Yasser Zaghloul today mentioned very important things, and they make my life easier, because he was saying there are lectures after me about ERAS, and I'm talking about preoperative recovery. This is included. That's why we say it's enhanced recovery after surgery, but it's divided into preoperative, intraoperative, and postoperative. So thank you, Yasser, for that. And thank you for explaining the anemia, which is you will make me able to cut a little bit of what I am going to say. And the post-operative as well, you mentioned about the impact of severe pain on the myocardial function, and it's a sort of stress. So peri-operative strategies which work synergistically, and synergistically means 1 + 1 here do not equal 2. 1 + 1 equal 3 and 4 and 5. Because when you do the thing as a package, ERAS is a package, then you will have a much improvement in the outcome than if you employ one of its essential components. And it improves the quality first. And that's why it's very important to remember that, because when ERAS started, it started as fast track surgery by Professor Henrik Kellett. And when the ERAS Society decided to adopt the fast track, they changed the name from fast track surgery into enhanced recovery after surgery, to say that when we are concerned more about the quality, fast enhanced recovery rather than the speed. And if you do better quality services to your patient, then you will get the speed as a byproduct. So it was very important for me to remind you about all these. This is the definition of ERAS. As anesthetists, we do preoperative, intraoperative, and postoperative. So preoperative assessment is essential. Patient optimization, as Yasser explained to you, for example, about anemia. And then we put the patient to sleep and we do anesthesia for the surgical procedure. And we look after the patient in the immediate postoperative period, not only in the recovery room, but in his room. So in the preoperative, we have the major five, the big five: anemia, control of the glucose level, nutrition, and every one of what I tell you can have its own lecture. So please remember that I'm trying to give you a hint about all the role of the anesthetist in ERAS. So every item of what I am mentioning can be a lecture. There is a lecture. I like my lecture about the role of nutrition in ERAS. It's very essential. Carbohydrate load and the proper hydration and the blood pressure control, which again Yasser mentioned as part of the intraoperative. So these are very important. Here, the blood pressure control is the preoperative one. The preoperative blood pressure. So if you have a hypertensive patient, you control. In other words, you try to optimize your patient, that when your patient comes for surgery, he will be, of course, I'm talking now about elective surgery. I'm talking now elective surgery. So you try to get your patient at the best possible condition for your patient for elective surgery. ERAS now is applicable for emergency surgery, but the preoperative part will be taken away. So we optimize the condition of the patient, such as anemia, diabetes, high blood pressure, cardiac condition, as mentioned, and it was illustrated to you by Yasser. Thank you, Yasser. We rationalize the medications the patient is taking. For example, anticoagulants and antiplatelet medication, we stop them and we do the bridging therapy. You are all aware. So control of medication, and we do that as part of our management for the patient. And then what Yasser didn't mention, because it's a very important part for us, but it's not about medication, is the patient education. This is ERAS, very, very essential in ERAS. Patient education, patient information in the best possible way. And now we are now in a webinar, so patients now and most of the hospitals are paperless, so we can give them videos, we can give them lots of things, because at the end of the day in ERAS, patients are partners in their care. Remember this, very important. We do everything for the patient, so they are partners. Again, the time where I was a medical student or a junior doctor, when I tell the patient, your the patient, I'm the doctor, you do as I tell you, has no longer place. Now the patient is partner in his or her care. We try to avoid sedative pre-medication at the day of surgery, very important in ERAS as well, unless it is really, really, really needed. And then we do something called the carbohydrate load, which you can take a lecture as well. And we allow free clear fluids up to 2 hours pre-operatively. Now, I think in the UK, they are making clear fluids for up to 1 hour only, but here I'm keeping 2 hours and I'm struggling to keep them 2 hours. We do the carbohydrate load, as I told you, it can be a lecture on its own, but in short, it avoids the dehydration of the patient. The patient feels better. It has metabolic effect, very important, because it reduces the insulin resistance, which can happen due to starvation, prolonged starvation. And there is no increased risk of aspiration. And we ensure the patient is compliant with the volume loading and not yet in diabetics. So in a healthy patient, not diabetic, you do a carbohydrate load, but not yet in diabetics. Some centers are experimenting to do it with diabetes or not. Antibiotic prophylaxis is very important. We don't do nasogastric tubes anymore. Routine nasogastric tubes are not used. Prophylaxis against postoperative nausea and vomiting, very important. We do use 2 different classes of drugs. Short-acting anesthetic agents, we'll talk about that. And the maintenance, if necessary, and monitoring. If you are using a non-depolarizing relaxant, you should monitor the neuromuscular block. You should have a monitor for the muscle relaxant. Essential, essential. Depth of anesthesia monitoring is essential in ERAS, and I will tell you why after that. Protective lung ventilation strategy, we use that in ERAS as well, and maintain normoglycemia to the best of our capabilities, and deep vein thrombosis prophylaxis, TED stocking, cuff compression devices, chemoprophylaxis for other cases, of course, for the thromboprophylaxis. And very important is to maintain normothermia for the patient. Very, very important. So you can see these are very important elements, and they are all evidence-based elements which we use intraoperatively in ERAS. When you use analgesia, you use analgesia to minimize the opioid needs post-operatively. Of course, all of you will remember the name opioid-free general anesthesia. There is nothing, and there will be nothing called opioid-free general anesthesia unless you have a typical and excellent nerve block and the site of the operation allow you to do that. But in major abdominal surgery, I prefer, much prefer the word minimal possible analgesia, or not minimal possible analgesia, it's minimal possible opioids. You do everything to minimize the use of opioids. But in some cases, if the patient needs analgesia and you've done everything else, then opioids are a must. Of course, we use goal-directed fluid therapy where appropriate to optimize the cardiac output, to maintain normovolemia, but to avoid fluid excess. We aim for normovolemia, and we try to maintain mean arterial blood pressure above 65 in a normal patient with vasopressors. But when we know that this patient is fluid not sensitive, not fluid responsive. If the patient is fluid responsive, we give volume to achieve the normovolemia. When you have normovolemia, then you give vasopressors. And this means that you monitor intraoperatively the the cardiac output by non-invasive monitors of the cardiac output. And I'm sure all of you now know that there are many non-invasive cardiac output monitoring. We maintain optimal hemoglobin for the patient and for the procedure. And I think Yasser has spoken about it and making my life easier now. So for antibiotic prophylaxis, we give single dose, and this dose should be given 15 minutes to 1 hour before skin incision. This is the best time to give antibiotic prophylaxis. We use further doses if the operation is longer than 3 hours or if the blood loss exceeds 1.5 liters. Then we use another dose of the antibiotic prophylaxis. And of course, we have to respect, or the hospital itself, the guideline should respect the antibiotic stewardship. And this is very important. And then sometimes in some centers, 2 further doses appear routine in some centers, not in others. And we do everything else apart from antibiotic prophylaxis to reduce the surgical site infection. For example, by maintaining normothermia, because hypothermia can increase the rate of surgical site infection, for example. Nasogastric, as I told you, can impair return of bowel function, disliked by the patient. It causes sore throat. It increases the incidence of postoperative fever, atelectasis, and pneumonia. Only so the right word, and the British are very clever in writing the right word. So they say routine nasogastric tubes is contraindicated. So it is not routine. So you have to, if you wanted to put a nasogastric tube. So only we insert it if there is gastric distension or requested by the surgeon. And even if it is requested by the surgeon, if you have a surgeon who doesn't believe in ERAS or who is not ERAS follower, you have to discuss. And this is what I was doing. And I know Nader Francis, he's Egyptian, by the way, and he's a surgeon. He's the president of the UK ERAS Society. And I used to call him and I tell him, my surgeon is saying this and this to put a nasogastric tube. Is that right? And he will tell me, yes, he's right, or no, he's not right. And then I can discuss it again. We can, of course, you can put it during the time of surgery, and at the end you can take it out. And it can protect from aspiration if ileus on the postoperative period. Nausea and vomiting is very important, very, very important. And I can promise all my patients that they will not suffer shivering or hypothermia. Definitely. I tell all my patients about that, and they will not suffer pain, severe pain. Okay, but I cannot promise them that they will not have postoperative nausea and vomiting. I always tell my patients in the preoperative, as part of the patient engagement and patient knowledge, is that I will do my best to minimize the incidence of postoperative nausea and vomiting. And thank God, the results of the centers I work in are usually below, the incidence of postoperative nausea and vomiting is below the international benchmarks. It means we are doing good work. But I cannot promise my patient 100% that they will not have nausea and vomiting. We do our best. We give prophylactic antiemetics, usually two, and all of you are aware of that. We use, I use granisetron, for example, and I use dexamethasone. I avoid the use of nitrous oxide. And of course, we use minimal possible opioids, as I explained to you. In patients with very high risk of postoperative nausea and vomiting, I consider seriously using propofol by TCI. It's usually TCI, propofol, and remifentanil as the way of anesthesia because they reduce the postoperative nausea and vomiting. When we use anesthetic agents, we go for the shortest possible, shortest acting agents. So for induction, I use propofol, opioids depending on the type of the operation, or no opioid. If I have a nerve block, ultrasound guided nerve block, which can help, and then we can definitely avoid any opioids. Short acting muscle relaxants, when you use them, sometimes in bariatric surgery, and this can be a lecture on its own, I use Presidex as pre-anesthetic medication as part of the multimodal analgesic technique to reduce the opioid, or going for opioid, near opioid free, minimal possible opioid. For maintenance, I don't use nitrous oxide, and I'm sure people from the UK, they now very rarely use nitrous oxide. We use air and oxygen mixture, and I use only desflurane. Yes, so you can achieve everything with SIVO, but desflurane is the best if you use it properly. And I think if you, as I told you, in ERAS, it's synergism. You get 1 + 1 do not equal 2, they equal 3 and 4 or 5. And I will show you that at the end of my surgery, my patients are fully awake, which you can achieve with SIVO still, but use the best you can use. And the desflurane, in my, not my opinion, because there is no opinion, but it's according to the blood gas solubility and according to the data of the drugs, it is the best. Remifentanil infusion for short-acting opioids, you use that. Of course, in general case or abdominal case. If you are using a neuromuscular blocker, ensure adequate muscle relaxation, facilitate surgery, of course, such as bariatric surgery, and the let the surgeon operate at a lower abdominal pressure, but at the end, ensure full reversal of the neuromuscular blocker. And this is very important, and monitoring is essential in that. Then when you use inhalational, if you are using inhalational, you should use anesthetic agent monitor and depth of anesthesia monitor. And the depth of anesthesia monitor, when it started first, they were starting it to avoid awareness. And actually, the only advantage of using inhalational drug is to avoid awareness. But now, what can you do to make sure that this patient is not taking too much anesthetic? If you are relying on the hemodynamics, you're very crude, and the MAC value is very crude. And I use, in any long operation, I use depth of anesthesia monitor. And by this, I found out that in many of our cases, I use much lower. I'm not achieving 1 MAC, or sometimes, or I go for half MAC, and I'm achieving the level of anesthesia I want. So this is very important, especially in the elderly, because it reduces the postoperative cognitive dysfunction, and this is very important. And there is something as well, which if you use the depth of anesthesia monitoring, there is PQRS, postoperative quality of recovery score, which is very important, and it shows if you are using desflurane, and if you are using depth of anesthesia monitoring, or if you are using total intravenous by TCI, TIVA-TCI, then the postoperative cognitive dysfunction is much less, and the recovery, the quality, the PQRS is much better. Perioperative glucose control, poor glycemic control increase the risk of complications, of course. So we need tight glycemic. If we use tight glycemic control, we increase the risk of hypoglycemic event. So we try to maintain normal glucose level. Remember that this is in glucose. You will find the same in fluid management. Not too tight, not too strict, and not too liberal. So normal, near normal is the best. خير الأمور الوسط. Short-term insulin glucose level necessary if the patient becomes insulin resistant. And If the patient becomes insulin resistant only because of anesthesia, it's the anesthetist fault. Because in your anesthesia, in your ERAS anesthesia, which should be the appropriate technique for all our patients, you should try to make it as much less stress response as possible. Body temperature, very important. And I can tell you, there are two reasons by which I introduced the ERAS to the whole Middle East. These two reasons, that when I came back from the UK and I came to practice in the Middle East, I found my patients, or some patients, not my own patients, but sometimes I found in recovery in many hospitals, patients are suffering from pain or shivering and hypothermia. In the proper anesthesia, and I insist on that, we do not treat hypothermia. We do not treat shivering. We prevent hypothermia, we prevent shivering. And this should be a key point indicator of any perioperative medicine department, anesthesia department, that hypothermia is preventable. And I don't think it's acceptable now to have any of our patients postoperatively with shivering. We use every possible way, warm air blowers, underbody heating, warm IV fluids, and it starts again. It's like exactly like ERAS. It starts from the preoperative. By patient education, we tell the patient that when they are in the room and the air condition is too cold, they have to inform the nurses to raise the temperature. So patient can walk to the anesthesia, to the theater. If not, there is contraindication for the patient to walk to the theater, but it's much better to walk to generate heat. And then we maintain normothermia and we look after it. I can dedicate another lecture completely for the prevention of unintentional hypothermia, because hypothermia increases the risk of wound infection, increase bleeding and transfusion requirements, shivering increase oxygen consumption, and it's a very distressful thing for the patient, and it worsens the pain scores. And if you prevent hypothermia, there is reduction of morbid myocardial events. So, and hypothermia can kill, simply. Hypothermia can kill. For the ventilation, of course, protective lung ventilation, I'm sure you are all much, much better than me in doing that. We use small tidal volume, 6 to 8 mils per kilogram, protects against lung damage, optimal PEEP, reduces microaspiration. But when you are using non-invasive cardiac output monitoring and you're using 6 mils per kilogram of the, for part of the protective lung ventilation, the readings are not very good. So I go for 8 mils in ventilated patient to allow the use of stroke volume variation and pulse pressure variability. Venous thromboembolism, we do scoring of the risk. We use TED stockings when possible, cuff compressions. Early mobilization in ERAS is very important. And of course, if the patient fulfills the criteria for early embolization, for prophylaxis, we use that, and extended prophylaxis, and fluid therapy can help a lot. Patients with cancer and chemotherapy and on chemotherapy, they are more likely to develop these, so we have to do extra efforts. Analgesia. Analgesia, simply opioid sparing. We minimize the use of opioid. We want effective analgesia because it's humanitarian, it's human for the patient not to suffer any pain. It allows mobilization, and we should avoid and do opioid sparing things. The oral multimodal, we use paracetamol plus non-steroidal unless contraindicated. So I use both of them routinely unless contraindicated by any reason. Oral, as I said, paracetamol and non-steroidal. Analgesia should be effective and allow mobilization and opioid sparing. We use central neuroaxial, we use truncal, such as tab blocks, rectus sheath catheters, and the blocks and wound infusion catheter, any way to prevent pain and to minimize opioids. Of course, there are now experts, and most of you are experts in the ultrasound guided nerve blocks, and this can lead, the only thing which I believe can lead to opioid-free anesthesia. So when you are dealing with analgesia for your patient, you wanted to optimize the patient comfort, you want the fast functional recovery of the patient, and you want few side effects. And when you do that, you encourage what we encourage postoperative dreams. And dreams means early drinking, early eating, early mobilization, and the proper sleeping for the patient. So this is our aim by good analgesia for our patient in the postoperative period. And of course, analgesia can take lectures and lectures for the role of analgesia and how can we give multimodal and opioid-free and minimal possible opioids. We come to the fluid, the same again. At certain time, they were giving liberal amount of fluid, which lead to hypervolemia and bowel edema. At other times, they were using restrictive fluid. So here is the restrictive fluid, which can lead to bowel ischemia. And when they give too much fluid, it leads to bowel edema. So overload is not good, underload is not good. We are working to reach this optimal spot. This is the best way, is to give the right amount of fluid. So restrictive is not good, liberal is not good. The optimal fluid therapy is to give the right amount of the right fluid at the right time. Remember this. And again, this can be a whole lecture and many lectures when we do that. So ERAS fluid therapy, we avoid fluid shifts. That's why we avoid bowel preparation. We give carbohydrate load, and we allow fluids up to 2 hours preoperatively. And then the patient will come to you in a state not dehydrated. And then intraoperative, we use individualized goal-directed fluid therapy to maintain normovolemia, to optimize the oxygen delivery to tissue. And when the patient is normovolemic, then you use vasopressors to maintain the mean arterial blood pressure to avoid hypotension. We optimize the hemoglobin, very important, and individualized, of course, because it depends on the patient and his condition, and Yasser spoken very nicely about this. We maintain normovolemia, we restrict salt and intravenous fluid, and we start early feeding. All my patients, or most of my patients, more than 90% of my patients will start drinking tea, coffee, juice, or water in the recovery room, even after bariatric surgery. The following significantly affect fluid shifts and requirements. Open surgery and prolonged surgery will delay that. Blood loss, of course, and prolonged systemic inflammatory response or sepsis, they will delay and they cause fluid shifts, and they are very detrimental to us. The vital organ optimization during surgery, and Yasser has mentioned that very nicely as well. We optimize the cardiac output, we optimize the oxygen and the nutrients delivery. Try to ensure normovolemia, See how many times I talked about that? And the monitoring, the non-invasive cardiac output monitor. I predict, and remember that I'm predicting from now that in the future, we will use non-invasive cardiac output monitors exactly as we are using blood pressure monitors now. Because of course, predicting and knowing exactly the volume status and the cardiac output, the flow is more important than knowing the pressure, because the pressure is a product of resistance to flow. We maintain the mean arterial blood pressure when the patient is normovolemic by vasopressor, and we optimize the hemoglobin. This is to give the minimal amount of intravenous fluid to achieve the above. Mean arterial pressure, does it matter? Of course. Yasser showed in his excellent lecture that it matters. It really, really matters. So for the mean arterial pressure, if it is reduced below 65, there is an increased risk of kidney injury, delirium, myocardial injury, as Yasser mentioned, infection. The effects of these delirious effects increase by the duration and the magnitude below 65. Then an individualized mean arterial blood pressure target, it should be individualized because this patient might be a hypertensive patient, so there is a shift of the response and to the oxygen delivery, etc. So, and the individualized mean arterial blood pressure target may be beneficial, but flow, as I told you, the cardiac output must be optimized first. So, in enhanced recovery, we give effective analgesia, individualized fluid therapy, and then in the post-operatively, early mobility of the patient is essential by effective analgesia as well. It will lead to early mobility. Enhanced recovery will have early gut function, very important, because we allow them to drink. We don't wait and we don't listen to peristalsis anymore. On the contrary, when you give chewing gum for the patient, they tend to do better. And when you let them drink in the recovery room, it's much better. And we try to modulate the stress response and minimize the stress response. Early gut function will lead to better healing. Early mobility will lead to decreased length of hospital stay. And the modulation of stress response will decrease the complications. I'm showing here a video for you for one of my patients, which we've done. It was not in my hospital. It was actually a workshop in the 3rd ERAS conference of the Middle East in Oman. And this patient received a long operation, about 4 hours. It was a 3rd redo for bariatric surgery. And you can see this patient in the recovery room in about 10 minutes. Oops, sorry, I wanted to go again. Yeah, I wanted to show the video. Sulaiman, we just finished the bypass operation. It's a redo. And he's now 10 minutes or 15 minutes in the recovery room. Sulaiman, how are you feeling? أخبارك إيه?
Good, alhamdulillah.
Alhamdulillah. Now we asked him to sit on the edge. So he will sit on the edge of the bed for 10 minutes. And then to make sure he's not drowsy, etc. And now I asked it. The nurses were amazed because they are not my normal nurses. And it was like for the first time they have seen this experience. And the patient to mobilize, assist him, assist. Okay. Down, yeah, and start to move. Start to move. Excellent. Yes. Stand up, take a nice deep breath, and start to move. Don't close your eyes, don't look down. So he walked, and he's coming back. So, ladies and gentlemen, it was an honor talking to you. Thank you very much for being such a great audience. And I hope all your patients will get benefit from using the ERAS protocols. And there are so many things in ERAS which need to be discussed and talked about. As I told you, every item I mentioned can have its own lecture or lectures, actually. It's an honor to be with you. Thank you very much for being such a great audience. Thank you.
Thank you, Dr. Medhat. It's really, really fantastic. Honestly, I really personally enjoyed it. To the point, really summarized and to the point. It's absolutely really one of the best lectures I've seen about the enhanced recovery. And thank
Thank
you
you
very
very
much.
much. Yeah. Thank you.
Um, I can I actually I encourage all this the attendance. Really, it's very important, guys, just to keep in touch with our experts. It's really Dr. Saad makes a great effort to keep them with us today. And it's if such a like some person, someone like an expert like Dr. Medhat, you will struggle if you get in touch with him. So keep on interacting and send questions. And it's this is the main aim. These lectures will be available in YouTube and available on our platform. However, extremely important to catch the chance of being in touch and getting interacted with the experts. So of course, Professor Medhat, it's really hot topic. And as you mentioned, I amazed with your patient in the recovery. I had a similar patient with a major colorectal, and we used to have such also in a previous era when we have to do an abdominoperineal surgeries, and the patients, go to the ITU with a lot of tube and a lot of
Exactly.
in and out, and patients getting sometimes intubated. And yeah, I started to believe personally in this in this fantastic way of managing patients from from a multidisciplinary pattern. It's not only about the anesthetic; it's also about the
Of
surgery,
course.
about the
Of course.
teamwork. And I remember as a such the same patient like you had at the end of your lecture. And I amazed that at the end, actually, we've done him done a major colorectal. And when I was going home at the end of my list, I've seen him actually sitting in Costa. So he was drinking coffee in Costa.
Exactly. Exactly.
Yeah, so this is absolutely, guys, it's really, it's nothing about only literature. It's also about from clinical aspect, like mentioned by Dr. Medhat. It's now an era of how we can move away from keeping patient hospital. Now, as you've expecting, Dr. Medhat, you have a lots of questions, and I will just select some of and I will keep the others for you, just to keep going with our program today. So, Dr. Ahmed Khattab, he's mentioned that is in ERAS protocol, why not periodizing TIVA versus inhalation-based anesthesia? I think you mentioned this, Dr.
Why,
Ahmed.
why, why again? What
Why
does he?
not periodizing TIVA versus
Of
inhalational-based?
course, we use SIVA a lot. I'm the vice president of the World
Yeah,
Society of Intravenous Anesthesia, but I always wanted to say I use TIVA a lot, but still, if you're using desflurane in the right way,
yeah,
you can achieve. And it's not about one thing. It's not about inhalational or intra. It's about
absolutely.
everything together. The
Excellent.
package,
Yes.
the
Excellent.
package.
Yes.
The
Yes.
the ro- any of these patients, if the patient was cold, he will never awake like this.
Yeah.
If the patient was in pain, he will never wake like
Absolutely.
this. So it's a whole thing together.
Yeah. Yeah. Absolutely. Absolutely agree 100%. So, Dr. Ahmed Khattab, as you heard from Dr. Medhat, it's a multimodal. It's something which is not about only one limb. It's just all about the whole thing together. It's like a package. So if you provide your patients with a multiple versatile ways of enhancing his recovery and keep him out of the bed, it does work. It's not only about one agent versus the other. Right. Professor Medhat, also you have a question here from again from Dr. Ahmed Khattab. What's the best carbohydrate load? So
It
I think
depends where he is in which country, because it's not
yeah,
available everywhere.
yeah,
It's available in Dubai. I found a company which can provide me with a carbohydrate load.
mm,
In the UK, there are many choices. In America, there is a company which became the best company just because they have a very good carbohydrate load. You can see it's a good business as well. So it depends. If you don't have in your hospital or in your country, I don't know where he practiced, if you don't have anything, then the least you can do, which is not like a good thing, a very good thing, but the least you can do is to ask them to drink clear apple juice.
mm, yeah, yeah.
But it doesn't fulfill but at least if the patient can drink or like to drink apple juice, I prefer it to water. So he can drink a lot of apple juice
Mm,
pre-operatively.
mm, mm, mm. I think there's out of the commercial thing, there's a lot of the energy drinks with sports they use.
Exactly, but avoid energy drinks. In Europe again,
Yeah.
there are energy drinks which can be, and this American company actually produces one, and then the sportsmen started to use it.
Okay. Okay.
So yeah.
That's fine. Right, Dr. Medhat. From Mohammed Suleiman is dexmedetomidine can delay recovery.
Sorry again.
So I think Residex.
Ah,
Yeah. So can delay recovery. So how to use it properly? I don't think that's good.
exactly. I can. There is another lecture I can promise you guys to give you a lecture about ERAS in bariatric surgery.
Yeah.
And this is the lecture which I show exactly how I use Presidex, because in ERAS, we don't like to give pre-medication. Okay? We don't use midazolam. I don't use midazolam at all.
Yeah.
So then patient coming for major surgery, major abdominal surgery, when they come to my holding area, I put an intravenous and I start Presidex.
Yeah.
As a pre-medication, because again, in the UK, we used to have anesthesia room where you induce and the patient goes to the room. But here in the Gulf, the patient goes to a huge room and the nurses are scrubbing and preparing. It's really very hostile to the patient to go, for example, going for oncology surgery, a man or a woman coming for a major oncology surgery, and they go into a room, sometimes cold. In my case, I never make the room cold. I make sure the room temperature is above 23 when the patient goes inside the room. And I urge all of you to do the same till the patient is covered and induced. And then I use in the holding area Presidex. So the patient will have good pre-medication pre-operatively, and I give the antibiotic, etc. And then I wheel the patient into the room. So he will be calmer. And this is part of the multimodal analgesia to minimize the use of opioids.
Yeah.
And then the patient recovery will be like this. So this patient, which you have seen, has had Presidex. It's one of the patients because he's a bariatric patient.
Just as a personal question, Dr. Medhat, do you find a difference in your clinical, because between the remifentanil and the Presidex for enhanced recovery? Do you have any specific preference?
But I wouldn't compare them, because the role of Presidex, as I explained to you, I use it pre-operative, and then I reduce the rate in intraoperative, and I don't use remifentanil. Okay,
yeah.
Remifentanil, I use it mainly, and it should be TCI again.
Yeah.
TCI remifentanil and the TCI propofol as TIVA TCI.
Yeah.
Then you have a TIVA TCI patient and a wonderful recovery.
Yeah.
So it is not, I am comparing this against this. I am using this to the best of its abilities, and I'm using that for the best of its abilities.
Yeah, that's fine. Dr. Medhat, thank you very much. Really, personally, I enjoyed it the most, and I wish we have you all every week with us here.
It's my pleasure, actually, and I think I'm an old man now. I'm in a time where I would love that all the new generations to see and to learn from us, to learn from our mistakes,
Yeah,
as well as to learn from the good things we say. But it's my pleasure and my honor, and I think it's a mission we should all do.
absolutely. Thank you very much, Professor Medhat, and have a lovely night.